Good afternoon, everyone. Today, very important topic, especially for EDIC 1 perspective. This is neurological disorders, because in the exam you will get around 8 to 12 questions from this domain. So that's why this is very important. So I will discuss some A-type questions with you. First question is, a 22-year-old man is admitted to the ICU for severe dehydration. Please mute yourself, and if you want to give answer, you can write your answer in the chat box. So a 22-year-old man is admitted to ICU for severe dehydration due to polydipsia. Vital signs: heart rate 110, blood pressure 92/48, respiratory rate is 28 breaths per minute, saturation 98% on 2 liters of oxygen. He is lethargic but following commands. Initial lab values: sodium is 128, potassium 4.7, chloride 94, bicarb 16, blood BUN 34, and creatinine is 1.2. Sugar is, glucose is 436 milligram per deciliter. He is volume resuscitated with normal saline and started appropriate medical therapy. Repeat lab values showing the bicarb 20 and BUN 28, creatinine 1.1, and glucose is now 202 milligram per deciliter. His mentation initially improved with treatment, but then he becomes obtunded and unresponsive. He requires intubation for airway protection. Which of the following is the most likely cause of this clinical picture? CPM, central pontine malnesis from rapid sodium correction, cerebral edema from rehydration and rapid correction of glucose, symptomatic hyponatremia, hypoactive delirium, and left hemispheric infarct. So what is your take in this? So somebody, is the screen clear to all participants? Yes, I hope the screen is clear to all. Answer is B. Somebody is saying Pradeepta Sen Gupta. Okay. So any other answer, or you have the same opinion? All of you have same opinion, or your answer is different from the B? So basically, what is the problem? Do you know what is corrected sodium? How will you correct sodium? Somebody is saying again B. Okay. So if you talk to corrected sodium, if sugar is 436, then what is the corrected sodium? So 436 minus 100, 336. So it is multiplied by 3.36 multiplied by 1.6. So it will be around 6. So it will be around 133, 134. So 133, 134 sodium is normal sodium. It's not hyponatremia. Then 202. At the sugar is 202 and sodium is, now sodium is 131. So again it is a, you can add at least 1.6. So it will be 133. So initially sodium was 133 and now still sodium is 133. There is no difference in the sodium. So CPM ruled out. So what is the cause of this obtundation and unresponsiveness? Cerebral edema from rehydration and rapid correction of glucose. C option is symptomatic hyponatremia. So there is no hyponatremia. That's why it is ruled out. Hypoactive delirium. It doesn't fit in the clinical picture. Left hemispheric infarct. So this is also not fit in the clinical picture, because this is a simple case of metabolic encephalopathy. So what is the cause of metabolic encephalopathy? It may be hyponatremia, but not so in this particular question. And maybe another thing is cerebral edema from rehydration and rapid correction of glucose. So correct answer is the B. If you have any doubt, you can raise your query. Otherwise, I will move forward. So I am not going into detail. I already explained the same thing written here. Question number 2. During a domestic dispute, a 22-year-old man is hit multiple times in the neck with a baseball bat. Now he is not able to move. On examination, he is unable to feel pain and temperature, but has vibration, sense, and proprioception. Which of the following syndrome best describes his injury? Central spinal cord syndrome, posterior spinal cord syndrome, anterior spinal cord syndrome, posterior spinal artery syndrome, and central spinal artery syndrome. Any answer? All the topics I have covered in this domain is very, very important from EDIC point of view. They always ask questions from these topics from the neurological disorder domain. One is metabolic encephalopathy or corrected sodium or CPM, central pontine myelonesis. So if you want to write, you can write the topics also. We call these topics as the high yield topics. High yield topics means question from one or another question should be asked from these high yield topics. So option C, okay, anterior spinal cord syndrome. So basically, this understanding of the neuroanatomy will help you in this case. So this is the incomplete spinal cord injury. There are three types of spinal cord injury. One is Brown-Sequard syndrome. Usual mechanism is penetrating trauma. There is a ipsilateral loss of motor function, vibratory sensation, and proprioception, and contralateral loss of spinothalamic tract, so loss of pain and temperature sensation. Excellent prognosis, 99% ambulatory at final follow-up. Second entity is central cord syndrome, and the mechanism of injury is the hyperextension mechanism. Sensory and motor deficit in upper extremity more than lower extremity. Prognosis, most have moderate but incomplete recovery in anterior cord. Please mute yourself. Anterior cord syndrome, the mechanism is the flexion injury. So there is a bilateral loss of motor function, pain and temperature sensation, and it is proprioception and vibratory sensation. It has very poor prognosis, only 10 to 20% chances of motor recovery. So this table is very important. You might get one question asked from these either Brown-Sequard syndrome, central cord syndrome, or anterior cord syndrome. So these symptom, prognosis, what is the mechanism of injury? This table is very, very important from examination point of view. You have to mug it up. Then another very important question. A 48-year-old woman present to ED obtended after worst headache of her life. Whenever you get this term, worst headache of her life, it means you are dealing subarachnoid hemorrhage, SAH. Head CT reveals SAH. While in the ED, her mental status worsens and she is intubated for airway protection. Repeat head CT reveals an increase in ventricular size, but no increase in bleeding. Which of the following is the most definitive course of action? Administer mannitol, place intraparenchymal intracranial pressure monitor, begin continuous EEG, place external ventricular drain and remove CSF, or last option is hyperventilate. So what is your take in this question? Somebody has given answer. D. I have got 3 or 4 responses and everyone in the same opinion. Place EVD and remove CSF. So absolutely right, because in SAH, there is a chances of the rebleeding during first 3 days. And in rebleeding, acute hydrocephalus, seizure, and non-convulsive status epilepticus. So they always ask the complication of subarachnoid hemorrhage. This is very important topic. Even you can get a complete long case of SAH in the EDIC 2 exam. So you can understand the importance of this topic. So they always ask 1 or 2 questions from this single topic, subarachnoid hemorrhage. So this is very high yield topic. Write down this thing, and they focus on the complication of the subarachnoid hemorrhage. So, and all the 4 complications, they are very important: rebleeding, acute hydrocephalus, seizure, and NCSC. The head CT did not show increased hemorrhage, but did show increase in the size of temporal horns of the ventricular system. So this is basically this is the acute hydrocephalus, and treatment is the removal of the CSF and putting the EVD, external ventricular drain. Then, next question. A 41-year-old male with a mechanical aortic valve who is on warfarin therapy is brought to emergency department by emergency medical services after acute onset of right-sided weakness. 1 hour ago, he had no symptom. Temperature is 98.4 degree Fahrenheit. Heart rate 90, blood pressure is 183/95, and respiratory rate is 18. On examination, he is a left gaze preferences, right homonymous hemianopia, right facial droop, right arm plesia, and right leg paresis. He is mute. NCCT head is normal. INR is 1.3. Which of the following treatment should the patient receive as early as possible, and for what reason? Endovascular therapy with a stent retriever because his clinical syndrome is consistent with a large vessel occlusion. Endovascular therapy with a stent retriever because he is on warfarin. So IV-RTP is contraindicated. Endovascular therapy with a stent retriever because systolic blood pressure is 183, and therefore IV recombinant thrombin inhibitor is a contraindicated, and IV-RTPA because there is no contraindication to it. So I have got one B. Okay. Option is B is endovascular therapy with a stent retriever because it's in warfarin. So IV-RTP is contraindicated. Any other answer? D. Yes. So answer is D. The most recently published American Heart Association guidelines suggests that patient eligible for IV recombinant tissue plasminogen activator should receive it even if endovascular treatment are being considered. Patient with large vessel occlusion may be eligible for endovascular therapy in addition to IV-RTPA, but IV-RTPA should not be withheld. So patient's INR is only 1.3. INR greater than 1.7 is contraindication, as is a systolic blood pressure greater than 185 millimeter mercury. So now things are very clear that if you have a patient of stroke with large vessel occlusion, you will give IV-RTPA, and IV-RTPA is not a contraindication for the thrombectomy or endovascular treatment. So you can still go endovascular treatment preferably within 6 hours or maybe in 12 hours, depends on the clinical condition of the patient. But IV-RTPA is not a contraindication for the any endovascular treatment. So nowadays they are more focusing on the stroke questions on the basis of these newer guidelines of the endovascular treatment, because nowadays endovascular treatment are more the guidelines are more in favor of endovascular treatment. But you have to understand this thing. If you have given or if you are planning of IV-RTPA, you should not withhold that thing because you are planning for the endovascular treatment. You can still go with the endovascular treatment even if you are patient on the IV-RTPA. So 29-year-old man hanged himself and is resuscitated at the site by emergency medical services for pulseless electrical activity arrest lasting 19 minutes. On arrival in ED, he is comatose. Temperature targeted therapy is initiated on ICU admission. He remains comatose 2 days after completion of hypothermia. His pupils becomes widely dilated without reaction to light. As the day progresses, he is declared dead by neurological criteria. Other than depression, he had no major medical illness before his hanging. His family has given consent for organ donation. Therapy has now been directed towards optimization of organ function before organ procurement. Which of the following hormone replacement strategy should be considered? So basically, they are asking question about the brain death and organ donation, and they are discussing hormone replacement strategy in a brain death patient. So thyroid supplement should be initiated with thyroxine rather than triiodothyronine. A vasopressin infusion should be considered for hypotension refractory to fluids. High-dose corticosteroids serve no utility and should not be administered. Hyperglycemia should be managed aggressively to achieve normoglycemia. So what is your answer? So this topic is very, very important in the EDIC 1, EDIC 2 both. They always ask question from the brain death and organ donation topic. So this is very high yield topic, even in EDIC 2 and EDIC 1, EDIC 2 both. So you have to go through this topic in quite detail. So somebody has given answer A, but answer is B. Why answer is B? A vasopressin infusion should be considered for hypotension refractory to fluid. So in all the situation of the hypotension refractory to fluid, the vasopressor of choice is the norepinephrine. But the only one condition in which vasopressin should be considered as the first vasopressor for the hypotension refractory to fluid in case of the brain death patients. That's why this answer is correct. So basically, I will read out for you one or two important lines. Endocrine deficiencies are common after brain death because hypothalamus and pituitary glands are susceptible to hypoxic injury. So not only is vasopressin of value in managing diabetes insipidus, which is common with brain death, but it also serves as a first line management of hypotension due to vasodilation or vasoplegia. So in the brain death patient, vasoplegia or vasodilation is the most important thing, along with the diabetes insipidus also common. That's why vasopressin is the vasopressors of the choice in case of brain death. Then 50-year-old male with history of hypertension is admitted to the ICU. Somebody answered Pradipta Sen Gupta, B. Okay, so B option was right in last question. Now question number 6. A 54-year-old man with a history of hypertension admitted to the ICU for evaluation of a left basal ganglia intracerebral hemorrhage measuring 45 ml and intraventricular hemorrhage. There is evidence of early onset of obstructive hydrocephalus. On admission, his GCS is 6 and intubated for mechanical ventilation. He also has a right hemiplegia with extensor posturing. Blood pressure is 198 by 109 millimeter of mercury. Heart rate is 109 beats per minute. Respiratory rate 24 breaths per minute. He has mild obesity. Which of the following IV intervention could potentially improve his chances of survival? Intraventricular tissue plasminogen activator, lowering systolic blood pressure to less than 140, hypothermia, anti-seizure medication for 7 days, insertion of an external ventricular drain. So I got answer B and E, and somebody has answered E. Okay, so answer is E. ICH is most destructive form of stroke. So management is ventilatory support, BP control, reversal of pre-existing coagulopathy, ICP monitoring, osmotherapy, fever control, seizure prophylaxis, treatment of hyperglycemia, and nutritional supplementation. So these each and every word is very important in the management of the ICH. Vent support, BP control, reversal of any pre-existing coagulopathy, ICP monitoring, osmotherapy, fever control, seizure prophylaxis, treatment of hyperglycemia, and nutritional supplementation. These are the cornerstones of the supportive care in ICU of a ICH patient. Ventricular drainage should be performed urgently in all stuporous or comatose patient with intraventricular bleed and acute hydrocephalus. So early placement of a ventricular drain in this case may save the patient's life. So answer E is absolutely right. Somebody told lowering systolic blood pressure to less than 140. We can do that, but this will not save the life, because in the question they have asked intervention which potentially improve his chances of survival. That's why answer E is properly fit in this situation. Next question. A 65-year-old woman with hypertension, paroxysmal atrial fibrillation, and hyperlipidemia who is not on anticoagulation is evaluated in emergency department with a large tertiary referral center with left-sided weakness that began 2 hours ago. On examination, she has a right gaze preference, left facial droop, left arm plesia, left leg paresis, dysarthria, dysphagia, and extinction of double simultaneous stimulation of the left. NIHS score is 17. Temperature is 37 degrees centigrade, heart rate 110, BP is 173 by 90, respiratory rate 20, NCCT head is normal. She is given IV recombinant tissue plasminogen activator, LT-place. So head CT angiogram shows right M1 MC occlusion. Which of the following is best next step? So once IV RTP infusion in complete recheck examination not improved, perform endovascular therapy with stent retriever. Wait 20 minutes, recheck examination if not improved. Wait 30 minutes, recheck examination if not improved. Order a CT perfusion to evaluate salvageable penumbra. Before deciding on antivenom, immediately perform endovascular therapy with stent retriever. Then again the same question which I have already asked earlier. They will always ask this type of question: what is the role of endovascular therapies in the stroke patient, and when will you do? First you will give RTPA, then recheck, or you will wait for some time, or simultaneously you will do. So definitely they will ask one or more questions from the acute ischemic stroke. So your answer is, I am getting this ECA. Okay. So you are a little bit confused, which is the right thing. I already told you will not recheck examination. There is no need of IV RTP infusion is complete. So answer is E. Basically, they are saying immediately perform endovascular therapy with stent retriever, because there is a large vessel occlusion, right M1 middle cerebral artery occlusion. So no need to check the response of the IV RTPA. You have to go for immediate endovascular therapy with stent retriever. So basically they are saying this thing. There is a class 1 level of evidence 1. They are saying patients should receive endovascular therapy with stent retriever if they meet all of the following criteria. First criteria is pre-stroke modified Rankin score 0 to 1, acute ischemic stroke receiving IV RTPA within 4.5 hours of arrest of onset, age more than 80 years, aspect score. So this is very important stroke scoring. Alberta Stroke Program early CT score. Please read it, this aspect score, when you read a topic of acute ischemic stroke. And you should know the NIHH score, National Institute of Health Stroke Scale score. So if it is NIHH score more than 6, aspect score is more than 6, age more than 18 years, patient is receiving IV RTPA within 4.5 hours, pre-stroke modified Rankin score 0 to 1. So these are the class 1 level of evidence A for the endovascular therapy in acute ischemic stroke. So you should read this topic well. Read this, because this is a very high topic. So acute ischemic stroke, they will always ask one question from this topic. Brain death and organ donation, they always ask one question from this topic. SH, ICH. So these are the very important topics in the neurological disorder. So I am just touching the higher topics so that you can understand in which areas of the neurological disorder you have to focus. So this topic is very important. I am telling you, you will get 1 or 2 questions from this concept. You are stroke patients comes to you, and there are some criteria in which you will do IV RTPA, and along with simultaneously you will prepare for the patient for the endovascular therapy with this stent retriever as soon as possible, if patient fulfills the criteria.